chat, they're wanting to put the emoji. So if you put whatever you're feeling today, we're hoping you're feeling good. Next. All right, this is our team. We're a great bunch of team, and if you ever want to join our team, let us know. But this is our Best for All operations team. We love each other. Teams so far, we've got quite a bit of teams, and I'm so proud of the state of Tennessee, wanting to make sure that the care that we give is best for all people. Thanks so much, team. Next. Today, we're going to talk about, we're going to let Dr. Rolanda Lister and Dr. Karen Skitzina welcome us. Alicia is going to talk about the PRIM data by language. And then, of course, we're going to have Genna Linton working with interpreters of spoken languages. We'll have a Q&A after that, which will be fun. And then Patty Scott's going to give us closing announcements. I almost said arguments, but closing announcements. So thank you so much for joining us. We're so glad you're here. Next. Greetings, Dr. Lister and Dr. Skitzina. Are you on?
Yes, I am here. I am so excited to join us for this learning session. Thank you to all of the teams that have taken the time to join us in this project. We hope that things are going well, and we want to use this opportunity to really lean on one another for advice and tricks on how to help our projects to go better. So I'm looking forward to sharing and receiving today. Thanks so much for being here.
Thanks, Dr. Lister. That was really lovely. Dr. Skitzina, just want to also welcome everybody to our learning session today. And guess what? This week in our state leadership meetings, we started planning for next year's TIPQC annual conference. So that's something to get excited about. And it's only gosh, it's July,
So, I mean,
right?
if she has a BPP, does she say have a BPP?
Dr. Gray. There we go.
Whoops, sometimes that happens. Anyways, we're excited to get started today. So welcome, everybody.
Hi, Alicia, you're on.
Thank you, Bonnie. So what prompted this great learning session that we have planned is looking at our PREM data by language. So if you can go to the next slide. We have about almost 20% of the PREM survey respondents indicate they speak another language outside of English. So when we looked at this data, specifically the questions that indicate I was treated differently by the healthcare team because of the language I speak, or I was treated differently by the healthcare team because of my ethnicity or culture, we do see some big differences there between English and non-English speakers. So if we can go to the next slide. Interestingly, people did not feel that they were not treated with respect and compassion during labor and delivery, or with respect and compassion by the healthcare team, and they did not feel very differently about the care they received as well. So this was a good sign, but they did indicate that they felt like they were being treated differently. So we are so excited to hear from Genna about how we can address this, and I'm going to turn it back to Bonnie to introduce Genna. Thank you all.
Thank you, Alicia. Great job. Well, everyone across the state, thanks for joining us. We have Genna Linton. She grew up in Atlanta, Georgia, where she started learning Spanish at the age of 12. After studying abroad in Argentina and later receiving her bachelor's degree in Spanish and geography from the University of Georgia, Genna left the United States and spent the next 7 years living abroad, including short stays in Ecuador, Chile, and Peru. She settled in Buenos Aires, where she spent the next 5 years. After returning to the United States in 2019, Genna began her career in interpretation. She became certified in English and Spanish medical interpreter by the National Board of Certification for Medical Interpreters in 2020 and recently renewed her certification this year. She is also a court-registered interpreter in the state of Tennessee. Genna currently works for Tennessee Language Center as a training specialist, educator, and program manager for a variety of courses, workshops, and webinars, and presentations offered by their agency. Ladies and gentlemen, Genna Linton. Thanks, Genna. Welcome aboard.
Thank you so much, Bonnie, for that introduction, and thank you everyone for joining me today. I am really excited to be here with you all, and I'm also here with the director of our interpretation and translation department, Richard Ponce de Leon, so AKA my boss. And Richard is here. I'll be giving the presentation, but Richard is here to help support with answering any of your questions. He's been doing this for a long time. He's an interpreter, translator, and very knowledgeable about this industry. So he's going to be here to support where needed. And with that, we'll go ahead and get started. So today's presentation is about working with interpreters of spoken languages. I did decide to call it spoken languages for a very specific reason, and that is because we are not talking today about working with interpreters, ASL interpreters. That is an altogether different topic that I'm not qualified to give you a training on. So today we're just focusing on working with interpreters of spoken languages. So we're going to talk about how interpreters work, some best practices for working with interpreters, and some nuances between working with an in-person interpreter or an interpreter who's appearing over video or over the phone. You know, I have been familiarized with the PRIM survey, and I spoke to Anastasia about this, and she is of course aware that some of the responses on that survey may be very much tied into a cultural issue, where patients don't feel that their culture is necessarily understood, and that affects the way that they receive care. So that's a whole nother topic, and I do highly recommend anyone who works with frequently with people, immigrant communities, to become familiarized with some of the nuances, the cultural nuances of those people that they work with. That is not the focus for today's presentation. Today, we're going to talk just very specifically about what interpreters do, how they work, so that we can work better with interpreters and have a much smoother experience when we do have to interact with patients who do not speak English. Right. And really quick before we get started, I am going to ask you all to go ahead and take out your phones and just help me with a survey. It's very easy for you to do. If you don't have your phone, that's okay. But all I need for you to do is take your phone out and scan the QR code, and you should be taken immediately to this question where you can type in your response. And these responses will really help me, especially when we come to answering questions at the end. So the first question is, what area of healthcare do you work in? Internal medicine, and I know obviously this is perinatal quality care, but more specifically, great, we have labor delivery, nursing education, great, mother baby, labor and delivery, data management, awesome. High risk, okay, OB director, mother baby, great. Social work, excellent. So we can see that obviously you're in perinatal care, but you're in different areas of perinatal care. The things that we're going to talk about today are really for all of you folks, no matter if you're in, working with high-risk patients or if you're working as a social worker with those particular patients. Okay. The next question is how do you mostly interact with interpreters? Is that mostly over the phone, over video, or in person? Okay, so we have the vast majority here are working with interpreters over the phone or over video. And that doesn't surprise me at all. More and more we see in particularly in medical interpretation that the tendency is to have interpreters over the phone or over video because of a cost issue. And it's also an availability issue. Getting a person there in an interpreter there in person is obviously more logistically challenging. So we'll discuss some nuances that we want to keep in mind when we're working with interpreters virtually. Okay, and last one, how often do you work with interpreters? Wow, almost every day. That's a lot. Once per week. Okay. So depending on the area that you're working in, this will vary, but I can see why y'all wanted to set up this particular type of presentation because there's a lot of you folks here that are working with interpreters very frequently. And so hopefully with this short presentation, you'll walk away with some knowledge that will help you to just for those interactions to run a little bit more smoothly. So the first thing I'm a very participatory kind of presenter, so hopefully you don't mind that I'm asking you to be a little involved here, but I do want to go ahead and ask you to help me define what is an interpreter. And in order to do this, I don't need a definition per se, but if you could just start, if you want to just unmute yourself and start giving me some words. What are words that you associate with interpreters? Single one-off words. And if there's anyone, I can't see the chat, but if there are people putting things in the chat box, I don't know if Anastasia or Bonnie is able to just read off some of the things that people are putting in the chat box.
Nothing yet, but I would say translate.
Good. Translate. Okay. What
Patient
else?
advocate.
Advocate. Okay, that's an interesting response.
We have helpful in the chat.
Helpful. Okay.
I would add required, mandatory.
Mandatory. Okay, absolutely. But what does an interpreter do? What are some words that come to mind when I ask you, what is the interpreter's role? What is the purpose of the interpreter?
They're the voice of the patient when they don't speak the same language as the person.
Okay. Anything else? Great.
We
So
have
thank
in the chat.
Sorry, go ahead.
I think they're the voice of both of us.
Voice of
We don't
both.
speak the same language.
Yep. Mm-hmm.
Yeah, I think they're definitely the voice of the patient, but they're also the voice of the healthcare provider who's trying to learn and provide the today.
Absolutely. Mm-hmm. Absolutely. Okay. So, and one interesting thing that didn't come up here, which is, really what the interpreter does is the word communication. So an interpreter facilitates communication. That is really the main principal goal of the interpreter, the main principal role. The reason for the interpreter to be there is to facilitate communication between two people that don't speak the same language. And I like to think of it as a medical interpreter is there to kind of create an environment that would mimic that of two people speaking the same language, right? So the interpreter is there creating a situation in which patient and provider can communicate directly with each other, just like they would if they were speaking the same language. That is the main purpose of the interpreter. Okay. And sometimes they are certified and sometimes they are not. We don't have statistics about this, but I would bet that the majority of interpreters that you are working with are not, in fact, medically certified. So just something to keep in mind as well. Just like with any other profession, interpreters do have ethics that they abide by in order to do their job professionally, to do their job well. I'm not going to go through all of the interpreter ethics. I'm just going to point out a few that I think are the most relevant for you all on this call. And the first one is that interpreters are HIPAA compliant. So when interpreters sign a contract with a language agency, they do have to sign that contract saying that they are familiar with HIPAA and that they will keep all of the information they learn in an encounter confidential. So that's a good sense of trust and confidence there, knowing that. Another hugely important ethical principle that we abide by as interpreters is that we are there again to facilitate communication. We are there to be accurate and to ensure the message is conveyed between the two parties accurately, right? That's why I put a parrot up here, because often when I work with kids, I kind of try to tell them I'm like a parrot. I just repeat what I hear exactly as I hear it. So the interpreters, one of the interpreter's ethical principles is, in fact, not to add, omit, or change any part of what you're saying or what the patient is saying. They are there to repeat the message exactly as they hear it, and again, create that environment that mimics two people speaking the same language. And then, of course, respect, impartiality, integrity. These are things that we also abide by as professional interpreters. And the ethics is usually considered our sort of rigid rules, if you will, and the standards of practice are our guidelines for following those rules. And I'm going to again bring this up here: accuracy. The number one standard of practice for a medical interpreter, for any interpreter for that matter, is accuracy. The interpreter does not add, omit, or change anything that was said. And you're going to hear me repeat this quite a bit because there's certainly, especially in the medical field, there's a lot of like misunderstanding about what the interpreter is there to do. And so I think it's important when we're working with interpreters that we understand interpreters can play different roles, but the most important role that they play and the most important standard of practice that they abide by is to make sure the message is transferring from one language to the other exactly as it was said. And we have this concept of communicative autonomy that's so very important to us. I, as the interpreter, don't want to make assumptions about what you want to say, about what I think you should say. I want you to have the power to speak your mind, to use your voice to say what you want to say. And I am there to make sure that you are able to do that, right? So that's number one. Another important standard practice, and again, I'm not going to go through all of these. You do have these in your handout that I gave you if you're interested in going through them. Is cultural awareness. So another important duty for the interpreter is to have, an understanding of the cultures that they interpret for, so that they can help guide medical professionals when there is a cultural misunderstanding, and vice versa. They also should be versed in biomedical culture here in America. And then another concept we have is role boundaries. So when the interpreter is there in their capacity as interpreter, that's all they should be doing. Now, many of you may work with staff interpreters in your hospital, and sometimes the role boundaries line gets a little bit blurred when we work with staff interpreters, and they can have a tendency, they're, more a part of the team. But generally speaking, when we work with interpreters, they are there in the capacity of facilitator of communication and nothing else. They're not social workers. They haven't been trained in social work. They're not nurses. They haven't been trained as nurses. They are linguists. They are language professionals, and that's what they're there to do. So we also want to make sure that we're not expecting the interpreters to do more than really what they're trained to do. Interpreters are not there to give opinions, right? They're not there to assist the nurse. Hey, can you hand me that syringe? Most of us interpreters have a very minimal training in biomedical safety. We haven't gone to medical school. We haven't gone to nursing school. Of course, there may be interpreters that have, but most of us have not. We are trained in a very specific way to be able to interpret, to be language professionals within a medical setting, right? We don't actually have training to tell a patient how they should not take their medication. And we also are not there to on the spot translate some very complex document, especially if they're legal documents. In any case, we know that, consent forms and things like that really should be discussed with a doctor in case there's any questions. So that's something else we want to keep in mind. The interpreters are trained for certain things and they're not trained for other things. We don't want to have the interpreter or expect the interpreter to fulfill certain roles that they're not trained to do, because this could actually be very dangerous. And so speaking of those roles, we usually visualize the roles in this form, because there is a hierarchy to them, where you can see that the main, most common, most important role that they're most often playing is that of conduit. And the least active role that the interpreter plays is that of advocate. Now, if you have staff interpreters, this may look a little bit more like a box, and that's okay. If you have staff interpreters in your hospital, they may be doing more, they may have a more active role in being the advocate figure for those non-English speaking patients. And that is okay, as long as, again, there's some very clear role boundaries about when the interpreter is stepping into the room with you as the nurse educator or you as the doctor, where you're going to have a conversation with that patient. When they're in that room with you, all they are doing, their main role is to transfer your message and to transfer the patient's message, right? And again, they may not have any training in social work. Now they can, and the other thing to keep in mind is that many of you mentioned that the majority of the ways in which you work with interpreters are over the phone or over video. Those are not staff interpreters, right? And this is how they are trained. So those interpreters you're talking to over the phone, that you're talking to over video, have been trained to keep advocacy to an absolute minimum, only in the case of harm for the patient. Right? So this is the most important role for the interpreter. I hate to make it sound so robotic, but in a sense it is a little bit robotic, and it's good that we have some sort of boundaries around that, because again, we want to constantly respecting the communicative autonomy of the people that we're working with. So we're conduits. The message, we get the message, we take it, we deliver it over to the patient. And then we get the message and we deliver it right back on over. We don't add, omit, or change anything. And you'll notice that interpreters too, particularly in-person interpreters, are going to even mimic gestures and tones. They're going to mimic movements. So they're very much like a parrot in that case. And another important piece of this role is that we're very transparent, right? So because of this role we play, just repeating what we hear exactly as we hear it, and that transparency piece, that's why you're going to hear interpreters speak in the first person. They repeat exactly what they hear, exactly as they hear it. So when you as the nurse educator say, I think we need to lower the dose on your medication, the interpreter is going to say in Spanish or Arabic or whatever it may be, I think we need to lower the dose on your medication, right? They're repeating exactly. And so it's important from your perspective that you're not saying, tell him, tell her, ask him, ask her. You don't need to do that, right? That's the beauty of the interpreter. You actually get to have a face-to-face conversation with that patient. That is what they're there to do, is enable you to have a direct relationship with your patient, right? So the interpreter is there to help support that. It's all about you having that relationship with your patient. You can speak directly to them. You don't need to say, he said, she said, tell him. because the interpreter is going to repeat everything as exactly as they hear it. And when the interpreter needs to, if let's say they didn't hear, or they need to ask for clarification or step into that role of clarifying a cultural concept, then what they'll do in that case is they will actually refer to themselves in the third person. So they will say, "This is the interpreter speaking. Can you please explain the term you used?" I know it sounds a little weird, but I'm telling you that there's a reason why it's done this way. It actually makes it very obvious what's going on. There's no confusion, right, when we do it this way. So as the person working with an interpreter, just try and keep that in mind. If you will allow for the interpreter to just repeat your words in the first person and only use third person when they're referring to themselves, it's actually going to create an environment where things are much more obvious. It's much more obvious who's speaking and who's saying what. Okay. As I mentioned, so that's our conduit role. We do sometimes have to clarify. We refer to ourselves in the third person, and sometimes we do also play that role of cultural broker. And usually what the interpreter will do when it comes to cultural broker is they will encourage you to ask a certain question. So, for example, you all work with new moms, and you might have noticed that, for example, in Hispanic culture, I don't know if any of you have ever noticed a new mom. Oops, sorry about that. If any of you have ever noticed a mother who is putting in a bracelet on their child's wrist, right? And sometimes that can be a little bit jarring for the nurses. It's like doesn't seem very hygienic or whatever it may be. Well, that's a cultural thing. It's to protect against evil eye. And so if you as the nurse are saying to the mother, "Hey, you need to take that off, like you can't have that," well, the interpreter may step in and say, "This is the interpreter speaking. I recommend that you ask the mom why that bracelet is so very important." So that is the idea there, where the interpreter can see where a cultural issue is causing a miscommunication, and they can step in to help encourage you to then direct your questions for better cultural competency. Now, that's our perfect interpreter. Now, maybe not all interpreters are doing that really well. I suppose it depends on, on each person's situation. You may be working with a company that has great interpreters. You may be working with a company that doesn't have so great interpreters. But this is really what medical interpreters are trained to do, is to bridge that gap when there is a cultural issue that's going to affect understanding. Okay, so we have different ways that we can facilitate communication. The way that is used most frequently, or the mode that's used most frequently in medical settings, is called consecutive. And the way consecutive works is, let's say you, the nurse, say something, you pause. Well, you, the nurse, say something, interpreter listens, they note take, you pause and allow the interpreter to then say that in the other language. Then the patient says something and the same process happens. The interpreter is listening, and there's a pause where the interpreter then delivers that message, right? This is the recommended mode of interpretation in medical settings. So this is the way that most interpreters are going to work within the settings that you guys work in. And I want to do a little activity. I feel like it's a little bit easier to understand how we can work best with interpreters in this mode if we have a sense of what it's like to actually do this process. So I'm again going to ask you all to participate a little bit here. Is that okay? I can't see everybody on the screen, but you can stay muted, so that's perfect. I'm not going to ask you to do anything too complicated here. What I want you to do is just listen. And If you want to have a notepad, then you can, a notepad and a pen, then you can feel free to do that. But what I want you to do is just listen to what I say. And once I finish speaking, I want you to repeat as best you can what I said. Can y'all do that for me? Okay, I'm getting a couple thumbs up. Okay, so again, I'm going to say something, I'm going to pause, and I want you to just repeat. Everybody's on mute. You're just doing this to yourself, okay? You're just talking out loud to yourself. Just repeat as best you can exactly what I said, okay? Y'all ready? This is my baby, John. Yesterday, I took my baby for a checkup. We went to see Dr. Tran. Dr. Tran is a specialist for children. He's a pediatrician. It was the first time we had seen him. First, Dr. Tran examined John. Then he asked me a lot of questions about how John was doing. He asked about how he eats, how he sleeps, and how he wets himself. He asked me about what things he can do, like smile. Dr. Tran said John was doing just fine, but then he got out a big needle. Why did he want to stick my baby if he was doing fine? It turns out he wanted to give John a vaccine. Vaccines help babies stay well. Okay, I'm not going to torture you guys too much. I'll stop it there. But and I know maybe some people could see my words. What are your thoughts on that? How did that go for you? And feel free to just speak or put, I see Bonnie, it got difficult the longer you spoke. Very good, right? So at first you were like, oh, this is easy, right? This is my baby John. And then what happened? It got harder and harder, right? Could you, at what point were you like, oh, I can't remember?
As you, again, as you kept getting longer and adding more to it, your feelings into it kind of thing, it just, then I started like reminiscing, what did that feel like? And then I was like, never mind, I'm lost.
Right?
Yeah. I felt like even if I could remember essentially what you said, the longer you went, the less I was going to get exactly what you said.
Mm-hmm. Mm-hmm. So what so that's what the interpreter does, right? And a good interpreter with good note-taking skills, I mean, could go much longer than that longest sentence we just went on, right? So the interpreter's listening, the active listening of an interpreter is so important. They're remembering what you said and then they're repeating your words exactly. And as Mark brought up, thankfully, you know, you could have summarized what I said, but how does that feel for you, Mark? Do you want people to summarize what you're saying, or would you like to be able for your words to be communicated to the patient as you said them?
Right, exactly. You
Yeah,
want to make sure you're saying exactly what they're saying, not giving an interpretation. Sorry to use that
exactly.
word, but you know what I mean.
Especially if you have an interpreter that you don't know that you've just called on the phone, you don't want them summarizing what you're saying, and that's not what they do. They're going to repeat exactly what you said, right? But in order to do that, they have to remember what was said. So what would you think are some good practices from your end as the person who's speaking that could maybe just make sure to support the interpreter's process of remembering and relaying the message exactly it was as it was said? What are maybe some things that you could do from your end?
somebody said speak one sentence at a time. And I do think that you say something and wait, because the faster we talk or the more we talk, it becomes harder and harder for somebody to respond unless you do sign language and they can rap. They can do faster, but the rest of us are not like that at all.
Great. Yeah. So we're using shorter, or we could say pausing more frequently. Right? Anything else?
Yeah, Jessica Cagle said not to overload with information.
Good, not to overload. Speaking one sentence at a time, Morgan says. Good. Spoken languages move at speed of sound. Sign languages move at speed of light. That's my supervisor always coming in with a joke. So yeah, so here's some things we can think about. And let me just be clear. My point here is not to tell you guys, hey, how can you make the interpreter's job as easy as possible? That's not the idea here. The idea is to give you some best practices for how to work with interpreters, just like you would have best practices for working with anyone. I mean, even with my colleague, we have some best practices in the office for how to work together as colleagues, right? These are some best practices so that the interpreter can really do their job really well, right? And that is going to make for a better experience between you and the patient. And it's hopefully going to change some of those survey results because the communication is more fluid, right? So as was mentioned, we're pausing frequently. Now, I'm not saying you have to pause after every sentence, but if we go on and on and on, then something's going to get lost, or if the interpreter should ask you for repetition, and then you're going to have to repeat. So honestly, it's taking longer anyways. We just need to be patient. Pause a little bit more frequently, and then you won't have as much need for the interpreter to ask you to repeat what you said because there's too much information. We're speaking directly to the patient, as I mentioned. We're using simple language, and this is true for English speakers too. We want to try to avoid using extremely complex, high-level, high-register medical terminology. Speaking clearly, avoiding jargon. I know that jargon is a way that we can connect with people, and I'm not saying that you can't make jokes or use idioms. Just know that sometimes they don't translate. So sometimes it can just create like a little bit of either a miscommunication or an awkward situation, frankly. Speak clearly, teach backs. This is so important. So if you're sensing that there's a miscommunication, hopefully the interpreter will bring that to your attention, but you can also use that opportunity to say, hey, okay, so how are you going to take your medication? And I know this is something y'all learn in school, and it's something that's frequently done in the medical field, but especially when you're working through an interpreter, those teachbacks could be even more helpful to make sure that your message has been received. And then, we just want to be patient because the fact of the matter is when we work with interpreters, everything's going to take longer. There's no way around it, right? So we just have to go in knowing that this is going to take a little bit longer. Some additional tips just from my own personal experience, and I'll move through this pretty quickly. First of all, as I mentioned before, sometimes the interpreter needs to clarify. So this is the interpreter speaking. Could you repeat the last part of what you said? In my experience, two things happen when an interpreter asks for repetition. One is that the person who was speaking doesn't actually remember what they said, and that's okay. I mean, it happens. But another thing that happens frequently is let's say the provider says, yeah, we'll need to do those lab tests again to check everything. And the interpreter asks for repetition, and the provider says, yeah, I mean, I was just saying that because of their situation and how they're really, we're really trying to make sure that we're double checking everything. We're going to have them come back again for labs, right? So what happened there? The interpreter asked for repetition. It wasn't because they didn't understand. Maybe they didn't hear properly, and the repetition, instead of just repeating what you've said turns into a much longer spiel. So what happens is not only does the original message get lost in time and space, but now there's this whole additional message that gets a little bit convoluted when we go to interpret. So if the interpreter asks you to repeat and you don't remember, happens. You know, you can change what you've said, that's fine. But if the interpreter says, "Hey, could you repeat that last part?" Just repeat exactly what you said, right? Because that's what the interpreter is looking for, is they just, you know, maybe just slip their mind and they just need you to repeat those last few words as you had said them before. Another thing that can happen frequently is that the patient and the provider sort of understand each other already. So maybe the patient speaks a little bit of English, maybe the provider speaks a little bit of Arabic. You know, the interpreter is there to bridge gaps, to help build a relationship between patient and provider. And so, you know, if as a medical interpreter, if I see that the patient and the provider are able to communicate with each other okay, I try to step back a little bit because I don't want to get in the way just to get in the way. But we also want to make sure that like there is real communication there. There's a lot of people who think they speak a certain language and they don't really have the level of language. So if you're not sure that you are really fluent in that language, then you're probably best using an interpreter because again, that can create some miscommunications that could affect the patient's care. And then if the patient is understanding, you know, again, the interpreter could step back a little bit, but I think the best practice for these cases is for it to be defined from the beginning. So you could say to the interpreter, "Listen, this patient speaks pretty good English. We usually are able to communicate no problem. Can you just be here in case we need you?" Right? And it's very clearly defined from the beginning how that interaction is going to go. Now, if you have a patient who thinks they speak really good English, but you kind of feel like you always feel like they're not really understanding, again, define it from the beginning and say to the interpreter, "This patient often will try to communicate in English, and I feel like they're not really understanding. Can we establish with the patient at the beginning that they need to make sure that they're pausing and allowing for you to interpret?" So we just really define how that interaction is going to go. And that is beneficial for all parties involved. Okay. And then another quick tip is just, you know, if we have a really serious case, like let's say it's an end of life discussion, or well, in your case, because it's perinatal, if there is a situation with the baby, maybe the baby was born with a genetic disorder or whatever it may be, whenever possible, have a conversation with your interpreter beforehand to let them know what's going to happen in that conversation, especially if they're sensitive topics. If you have the time, just sit down and go and show the interpreter, "Look, this is the case that we're dealing with. I'm about to go in and tell mom that the baby's left ventricle is too small, and we're going to have to put them we're going to have to monitor them in the hospital for at least the next 3 months." You know, if you're going to have that really serious conversation, it is good practice to have at least a brief conversation with the interpreter ahead of time, so that any issues that might arise can be nipped in the bud before you go into that really intense conversation. And I know I'm supposed to be finishing up here. I just have a few more slides though for you, and then I will open it up for questions. So the last thing we'll talk about is just some things to keep in mind when you're specifically working with interpreters over the phone or virtually. First of all, positioning is very important. So if the person is over video, we want to position them as best as possible in a place where they can see. Whether they're over the phone or over video, we want to make sure they can hear. That is so important. One of the biggest issues that video and telephonic interpreters have is that they can't hear. So we want to make sure before we begin to really think about the positioning here, where can we position the phone or the video so that the interpreter has the best chance of hearing, because the interpreter can't interpret what they can't hear. And also we want to keep in mind that this here is a video interpreter. So she can more or less see what's going on. But even with video and certainly with phone, so this is over the phone and video remote interpreting, even with video, the visual is not really there. So as I mentioned before, the interpreter will mimic even movements and gestures. Well, that's going to kind of be lost, right? Because the interpreter can't really see, especially if they're over the phone, they're not going to be able to see. So you want to keep in mind that the visual is gone. And this is going to be especially important when we have, for example, this happens a lot and in person as well, that the provider has a sheet. Let's say they've printed out a sheet of the patient's labs. And so the provider will say, okay, so this, your white blood count, this number here, that's looking good. This number here is also looking good. Your hemoglobin is a little low. This, and we need to monitor that. We also need to monitor this number. So what happens when I go to interpret that? It looks like this. This number here is looking good. This number, your red blood count, is looking good. Your hemoglobin is a little low, and this number we also need to monitor. You can't see, right? We've lost the visual. So a good practice is if you are going to go over something where you're pointing out a visual, something visual, there you absolutely need to do one thing at a time. This number here, your white blood count, looks good. Pause, stop, leave your pen on the paper, or leave your marker, or leave your finger wherever you're pointing until the interpreter finishes interpreting, right? Because otherwise it's very awkward for the patient. They really don't know what you're talking about because the visual that you were depending on for your communication has gone away. Does that make sense? And we'll leave questions, of course, at the end. Okay, and last thing is that we also want to keep in mind when you're over the phone, the first thing that you really want to do is make the interpreter aware of everyone in the room, especially if there's going to be multiple people speaking. So when you get on the call with the interpreter, say, okay, hey, interpreter, I'm here with the patient, Mr. Morales. I'm also here with my medical assistant who is going to begin the conversation. And you might also hear a third voice from our attending who is just monitoring the situation. Okay, so we definitely want to point out all the parties involved. We also want to make the interpreter aware of a long pause. I can't tell you how many medical staff members have said to me, oh, well, I had the interpreter on the phone and then they just hung up. Well, what happens sometimes is for a telephonic interpreter, they don't know what's going on because they can't see. So let's say the provider steps out of the room for a minute, the interpreter doesn't know, and then nobody's answering, that nobody's saying anything. They're kind of like confused about what's going on. So if there's going to be a long pause, just say, hey, interpreter, just want to let you know I'm stepping out of the room to go grab my attending. I'll be back in about 5 minutes. Please stay on the call, right? And then finally, if you do have a telephonic interpreter, please note that the interpreter at the very beginning of the call, the moment they connect, they're going to give you their interpreter number. So this is good for your documentation purposes. If you can, I know y'all are doing a lot of stuff, but if you can take a moment before you actually start that call and get yourself ready with pen and paper or your electronic record system, whatever you use, and be ready to take note of the time the call starts and the number that the interpreter gives you. So that way you can track whether or not you want to get that interpreter again, or if you have an issue and you want to make that issue known. The interpreter ID number is going to come at the very beginning of the call, right as they connect. Okay. And then this is in your handout. I found this online and it's pretty useful. These are some do's and don'ts of working with interpreters in terms of how to document, right? So you want to document if the patient refuses an interpreter, et cetera, et cetera. So with that, this is in your handout. So I'll go ahead and stop it there and open it up for questions so that we're not going too far over time here.
That was wonderful, Jenna. Thank you.
So it went by quickly. Woof.
It did. If anyone has questions, you're welcome to put them in the chat or come off mute. I'd be happy to read them as well.
And I know that's a lot of information. I do want to just point out that you have been provided a handout where I've provided some of this information in written form. And then also I provided a handout that was shared with you that looks like this. And I thought this is from the Association of American Medical Colleges. This is a really useful handout, and it does actually talk about when you have to use an ad hoc interpreter, right? As in like a family member, and some best practices. And this is also a really nice, quick and easy sheet for you to refer to.
I know one of the questions that we had when we were talking as a leadership team was how to navigate hard to find dialects if your normal interpretation service doesn't have that dialect that the patient needs.
Mm-hmm. Yeah, this is very tricky. You have certain language providers that are very specific. So for example, Mayan Interpreters is a language service provider who works specifically with interpreters who speak Mayan languages.
Pushing that now. No.
It is very hard for you to know what the patient speaks, especially if it's a rare dialect. So that is challenging. And Richard, also feel free to chime in whenever and wherever. Usually if you have a rare dialect, the language line is going to be your only source, and it's not a guarantee that you're going to find the interpreter on the language line. Sometimes we have a situation where we just don't have interpreters for that language, and that is unfortunate. But the first step is to try to do your best to find out actually what language that person speaks, and don't try your best not to assume because of the name that they speak Spanish, because it's very possible that they speak Spanish as a second language.
And I just want to highlight, Jenna, that Maya languages are completely unrelated to Spanish or any other European language. Spanish is closer, or English is closer to Spanish, to Persian, Kurdish, Hindi, and German than it is to any of the Maya languages. They belong to completely different language families, so they may speak a little bit of Spanish, but if you try to use a Spanish interpreter, you might as well talk to them in English in some cases.
Yeah, and a lot of times when you have extremely rare dialects, many times the only option that you're going to have, as I mentioned, if maybe they're on the language line, but if they're not on the language line, the only option that you're going to have is what we call an ad hoc interpreter, which would be like a friend of the patient or a family member of the patient. That is, honestly, it's not an ideal situation, but sometimes you don't have a choice. And if you're in that situation where you know it's going to be a family member, which it should never be a child, but let's say a brother or another daughter, family member, or a friend that's going to interpret, you can again refer to these guidelines about using an ad hoc interpreter so that you as the provider can begin that conversation, setting up an environment where the person who's going to interpret understands what you need from them. Right? So you can say, listen, normally when we work with interpreters, the interpreters repeat what I say exactly as I say it. Now, knowing that that person is not a trained interpreter, they haven't been training their memory, there we want to really keep that in mind and maybe speak one sentence at a time. Really like take our best practices for working with interpreters and just really amplify them and really condense what we're saying, because we know the person that we're working with is not actually trained to interpret. So we want to really provide them with as little, shortest sentences as possible so that we can, as best we can, utilize them in the way we would an interpreter.
That's great info. Thank you. Well, for the sake of time, we will go forward with the rest of the presentation, but really appreciate that. And we did record, so we will send that out to the group. And Kiwana, were you able to join? She was having some issues with the Teams link, so I'm not sure if she was here. She is our patient and family partner. All right. And then I will turn it over to Patty to take us to our closing.
Sorry, I was putting something in the chat. Since I get to talk now, I'll just say thank you very much. That was excellent. And really appreciate those resources. All right. So have you been able to attend one of the regional simulation trainings? It's not too late if you have not. We still have a couple more. We'll be in Kingsport next week on July 14th, and then we'll be in Memphis with Bonnie on July 30th. So please, if you could aim for at least one of your team members being able to join, that would be amazing. We would love to have you. Next slide. We also have regional OUD and SUD trainings coming up, navigating obstetric and infant care for pregnant women with substance use disorder and their infants. Again, you can see the dates here, July 24th in Knoxville, July 25th in Johnson City, August 5th in Memphis, August 6th here in Nashville, and then the 25th of August in Chattanooga. There is no cost, and this is led by Doctors Jessica Young, Anna Murad, and Julia Wood. It'll be excellent. Again, if you could send at least one member of your Best for All team per hospital, that would be amazing. And I think you would find it to be well worth your time. Next slide. What about your regional community resource council meetings? This is something that's been going on in TIPQC for, I guess, maybe a year, maybe 2 years now. And you can see these are a way to connect with like-minded individuals and perinatal organizations in your area. Again, Knoxville on July 24th, Johnson City on the 25th, Memphis on the 5th of August, Nashville the 6th of August, Chattanooga the 25th of August. And you can see more information there. We have doula continuing education scheduled for August of 2025. And you can see, again, we're hitting all the regions. So please, if there's someone that you think would benefit from this training, we would love to have them participate. Next slide. Prem office hours, Wednesday, July 16th at 10 a.m. That's Central. If there are questions or challenges you want to discuss with the TIPQC team, they would love to talk to you about that. Optional time to discuss strategy, and then team links to follow. The Simple QI website has all the project resources. I say this all the time. People get tired of me saying it, I'm sure. I love the way all the sites are willing to share information. We are very non-discriminatory about sharing between hospitals and between systems. I love that about TIPQC. So please share your resources and, of course, partake of the resources that have been shared. Keep calm and mark your calendar. Our next huddle will be August the 14th. There is some homework. Your Q2 2025 data is due in Simple QI. And remember, we've got a lot of trainings coming up, so please register. Again, if just one member from your Best for All team could attend per hospital, that would be amazing. They could come back and share that information with the rest of the team. All right. Anybody have any questions or anything that they would like to share before we give you back a little bit of your afternoon? Of course, we've got our post-huddle survey. Let us know what we can do better. And we appreciate everyone's attendance today. And we want to thank Genna again for sharing her expertise and her time with our group. We really appreciate it, guys.
Thank
Anastasia?
you.
Yes, thank you, Genna. Anastasia, do you have anything you want to add?
I don't, but thank you, Genna, so much. That was wonderful. And we will get that posted on the Simple QI resource page for everybody.
All right, guys, we appreciate you. Keep up the hard work and let us know how we can help.
Thank you.
Thank you, Genna. Bye-bye, everybody.
Bye.